All right, everyone. Thank you for attending today's webinar, Addressing Legal Obstacles to Hiring Formerly Incarcerated Individuals as Community Health Workers, presented by the Network for Public Health Law. Please, for today's webinar, use the Q&A feature below to ask questions. We'll have all of our speakers answer questions at the end, so please hold your questions for then. Your host for today's webinar will be Colleen Healy-Bofides, who is the director of the Mid-States region here at the network. And I'll pass it off to her to introduce the rest of our speakers.
Great, thank you, Daniel. And good afternoon, everyone. Thank you for joining us today. As Daniel said, my name is Colleen Healy-Bofides. I am co-director of the network's Mid-States Region Office, and I'll be your moderator today. The Network for Public Health Law and Transitions Clinic Network recently partnered on an issue brief on the topic for today's webinar. And so that was kind of the impetus for this webinar today. Our work together on this issue stems from three key facts that I want to just highlight as we get started. So the first is that individuals returning from incarceration have more and different healthcare needs than the general population, generally speaking. The second is that community health workers, or CHWs, who have lived experience of incarceration, are uniquely suited to engage returning community members in health services. And then finally, nationwide, more than 44,000 policies and laws impede reentry after incarceration. These laws affect access to housing and employment, professional licensure, and many other aspects of daily life. Together, they undermine reentry efforts and increase the likelihood of recidivism. Together, these three facts lead to the circumstance that we're addressing today, which is that we need CHWs with lived experience of incarceration to best serve individuals returning from incarceration, but legal barriers impede hiring them. So with that, I'd like to introduce our four speakers today. First up, we have James Mackey and Shira Shavit with the Transitions Clinic Network, or TCN. James Mackey is National Program Manager at TCN. Prior to joining the Transitions Clinic Network as National Program Manager, James worked as a community health worker and then Program Manager and Supervisor of Case Management with community medical centers in Stockton, California. James received his bachelor's degree from the University of the Pacific in 1987, a Master of Humanities degree from CSU Dominguez Hills in 2008 while incarcerated, completed the University of the Pacific Master of Social Work program, and a Doctorate of Health Sciences degree. During his 28 years of incarceration, he spent 25 as a participant, facilitator, and mentor in self-help programs. 10 years as a clerk and 7 years as a mental health aide while incarcerated prepared James for many roles, but none could have fit more perfectly than the role of social worker and community health worker and TCN National Program Manager. Shira Shavit is a clinical professor of family and community medicine at the University of California in San Francisco and the executive director of the Transitions Clinic Network. For nearly 2 decades, Dr. Shavit has been redefining national best practices for the care for chronically ill individuals and communities impacted by mass incarceration. Under her leadership, the TCN model grew from the flagship program in San Francisco, where she continues to treat patients, to 48 health systems nationwide. In California, Dr. Shavit oversees a statewide network of 21 primary care systems that proved instrumental in supporting the increased number of individuals releasing from prison during the COVID-19 pandemic. Dr. Shavit graduated from Washington University in St. Louis, completed her MD at Rush University in Chicago, and completed her residency training at the University of California, San Francisco. She is a recipient of the Robert Wood Johnson Community Health Leader Award, completed a CHCF Health Care Leadership Fellowship, and was recently recognized with a UCSF Chancellor's Award for Public Service. Additionally, she is a member of the California Department of Healthcare Services CalAIM Justice Involved Initiative Stakeholder Group. Susan Florent is an Equal Justice Works Fellow and staff attorney for the Network for Public Health Law's Mid-States Region Office. She previously worked with the network for 3 years as a law student, and her work focuses primarily on public health legal authority and data privacy. Before joining the network, Susan practiced disability rights law. She received her law degree and Master of Public Health and Health Management and Policy from the University of Michigan and her Bachelor of Arts degree from Colby College. Susan is admitted to practice law in Minnesota. And our final speaker today is Monses Franco, who is a project coordinator and community engagement specialist with the Health, Homelessness, and Criminal Justice Lab at the Hennepin Healthcare Research Institute in Minnesota. He comes to the HHCJ lab with extensive experience in community engagement within the justice-involved community and as an advocate on behalf of persons living with HIV. It is his lived experiences combined with the development of community-building skill sets that contribute to HHCJ's community-based research efforts and advocacy. He is invested in person-centered approaches and holds a commitment to eliminating barriers and disparities that exist for marginalized people and communities. Outside of work, Monses is involved in many community organizations, including the Aliveness Project as a board member, the Office of the Ombuds for Corrections Advisory Group as an advisory member, the University of Minnesota Advisory Board, a former advisory member, and Minnesota Second Chance Coalition as a board member and co-chair of the training committee, and as well as the Minnesota Freedom Fund as a board member. Huge thanks to all four of our speakers for joining us today and sharing their expertise. First, Shira and James from the Transitions Clinic Network will discuss the issue and need for community health workers with lived experience of incarceration, along with TCN's model to address that need. Susan will then discuss the legal barriers and policy recommendations, and Monses will share his experience in Minnesota. We will have time at the end for questions and discussion, so please feel free to add your questions to the chat. And just to review quickly the goals for this webinar, we are hoping you will understand legal barriers to hiring healthcare workers with conviction records, learn about the Transitions Clinic Network model, which promotes hiring CHWs with incarceration histories to serve returning community members in primary care settings, and hear about a direct experience illustrating the impact of state laws that present barriers to employment. So with that, I will turn it over to James.
Good morning, everyone. Thank you for being with us here today. As Colleen said, my name is James Mackey, and I serve as the National Program Manager of Transitions Clinic Network. And I'm here today with our Executive Director, Dr. Shira Shavit. I'm honored to share with you the impactful work we're doing. And I'd like to start by introducing you to TCN, our mission, and kind of why what we do what we do. So next slide. Next slide. Okay. All right, there you go. Thank you. TCN is a capacity building organization dedicated to transforming the healthcare system to better meet the complex needs of folks returning from incarceration. And we do this by providing training and technical assistance to our clinic partners. And the program was started about 18 years ago in San Francisco, and it really just took off, and that's mainly because the program is rooted in the experiences of the community. TCN had community meetings and informal focus groups with formerly incarcerated individuals, and those were principled on the belief that the best healthcare interventions are those that people will use and that are tailored to those people's needs. And those folks told TCN what they wanted, and what some of those things were that they should be involved in the development, implementation, and evaluation of these programs, and that they should be the ones who defined what health and well-being was to them. And they also said that system should be patient-centered, that they should empower patients, they should favor reintegration, and they definitely should not replicate the harms of the carceral system. Next slide. So nationally, we work with 48 health systems in 14 states in Puerto Rico to implement the TCN model of care, which I'll talk about shortly. We not only train the community health workers at these sites, but also the providers and support staff who will be interacting with patients returning from incarceration. And we'll go into that a little deeper as we go along. Next slide. So our model is simple yet profound. We partner with existing clinic programs to implement enhanced primary care for returning community members. At the heart of our model is having community health workers with lived experience of incarceration kind of embedded, excuse me, within the healthcare team. The CHWs that we work with are more than just healthcare providers. That they really are lifelines for these patients. They understand those unique challenges, excuse me, and those barriers that are faced by folks transitioning back into the community. And by leveraging that shared history, pardon me, they build these relationships with patients, these trusting relationships, and ensure that that their needs are not only met, but they're understood on a deeper level. They have been there, so they understand what these people are going through, and they do something of the same for providers. They act as interpreters of patients' questions and needs, and they do the same thing for patients, and helping them to understand what the providers are saying. And next slide. So these are some of the services provided by CHWs with histories of incarceration, and these outreach and engagement activities. These are basic. It comes down to meeting patients where they are. So wherever that may be, jail, prison, homeless, on the street, where we will our CHWs meet them there. And as far as healthcare navigation, these you see here are some of the things that we help them do. Next slide. And next slide. So we know that our model works because it's been proven. Participation in our program has been shown to reduce the number of ED visits for our patients. They have fewer preventable hospitalizations and less probation and parole violations. So less people returning to jail and prison. Next slide. And this is some of our programmatic data that found that when patients were referred to healthcare pre-release from jail staff, 33% showed up for appointments. When patients were engaged with a CHW with a history of incarceration pre-release, that number jumped up to 70%. So it really, really makes a difference. Next slide. And this shows just the enormous loss when people have to face those consequences of incarceration that Colleen spoke about. 317 billion in earning potential lost every year for people with a record. And basically, and it comes down to, we have to hire people with lived experience because it builds health equity and improves health and reentry outcomes. Next slide. As I'm sure most of you are aware, Black and brown people are heavily overrepresented in the United States carceral system. So these numbers here, they should come as no surprise. But what I like to point out here is that the TCN model is helping to promote the representation of Black and brown people in healthcare positions and strengthens under-resourced communities in need of healthcare workers. And I am, in fact, one of the people represented by these statistics. In fact, I'm in this picture. I'm in the back row in the photo. When I came home 6 years ago, all I knew was that I wanted to make a difference in my community. And when the new TCN clinic in my hometown of Stockton, California called, and the director of behavioral health there offered me the CHW position, my mind, it just exploded with possibilities. And those possibilities may never have been possible without TCN. As Colleen said, since then, I went back to school on a master's of social work degree and a doctor of health science degree. And I owe much of that to TCN. Next slide. So At TCN, we understand the importance of addressing the systemic barriers that prevent formerly incarcerated individuals from having access to meaningful employment opportunities, particularly in healthcare, which is why TCN prioritizes hiring CHWs with histories of incarceration and providing them with opportunities to work in a field where they've traditionally been excluded from. This is the TCN 360 approach and how we work with our clinic partners to develop and implement the TCN model, providing training for CHWs, helping the HR departments with create job descriptions, being part of interview panels and things of this nature, and making sure that those CHWs are supported in the clinics. Next slide. So the brief, this brief was a great opportunity for TCN to collaborate with our friends at the Network for Public Health Law. The healthcare sector is one of the largest growing sectors in the country, and with the advent of the new federal 1115 waiver, we're hoping that states will use it to address some of the barriers to hiring people with lived experience of incarceration. In this brief, it's made pretty clear that our model not only addresses the healthcare needs of individuals returning from incarceration, but also demonstrates a pretty substantial cost savings potential for state budgets. It highlights the importance of investing in enhanced primary care programs like TCN as a means to not only improve health equity, but also alleviate the financial burden on state resources. In fact, we found that every dollar invested in TCN saved the state $2.55. It's amazing. It's amazing. And here's the bottom line before I give this back to Susan. TCN believes in redemption and the transformative potential of individuals who've been through the justice system. And yeah, we have a lot of evidence to prove that this program works. But also, I just want to point out that you're looking at it right here. Thank you.
Thanks so much, James, for that and for sharing your own story and the background on the TCN model and the real need for it. I'm now going to turn to discussing the legal barriers that show up, and all of this information is also in the issue brief that James was just discussing. So really thrilled to share it all with you today. You can go to the next slide. Quick overview of what I'll be covering. First, we'll start with the role of federal law and then address the state level legal barriers. And we'll talk about opportunities and policy recommendations coming out of the issue brief that we put together. Next slide. This is just a standard disclaimer. This is for informational purposes only. I am not providing legal advice today. I am not your attorney, so please contact your own legal counsel with any questions regarding legal advice. Next slide. So first, this graphic shows the set of barriers that arise at different phases of seeking employment as a community health worker. And, as James discussed, community health workers with lived experience of incarceration are central to the TCN model of care, but individuals with histories of incarceration encounter significant barriers to becoming employed within health systems. And so here you can see the barriers that exist along the employment continuum. And while laws vary state to state, there are some commonalities in the policies blocking individuals with criminal convictions from participating in the healthcare workforce. The first set of barriers may arise in states that have introduced certification opportunities or requirements for CHWs. I'll discuss this a bit more in detail, but the key here is to note that legal barriers can prevent potential CHWs with histories of incarceration from accessing and completing education and training programs or from ultimately obtaining certification. And then a second set of barriers are state hiring restrictions that may impede employment of qualified CHWs in healthcare settings. We'll discuss each of these issues in a bit. And I also want to clarify, we did not conduct a 50-state survey of all possible relevant state laws, nor did we attempt to identify all of those laws. We focused on the key issues that have shown up in TCN's experience. You can go to the next slide. So before getting into the state legal barriers, I do want to briefly touch on the role of federal law. I'll focus mostly on state law, and that's because healthcare and other professions are primarily regulated at the state rather than the federal level. Nevertheless, federal law influences CHW employment, including through funding programs such as Medicaid, as James referenced about the Section 1115 waivers, as well as through federal employment protections. With respect to employment, the U.S. Supreme Court has held that states may not exclude individuals from occupations in a manner or for reasons that contravene the Due Process or Equal Protection Clause of the 14th Amendment. So essentially, this means that a state cannot exclude an applicant from practicing a profession or occupation unless the reason for disqualification is rationally related to the applicant's fitness or capacity to perform that occupation. Another relevant federal law is Title VII of the Federal Civil Rights Act of 1964. This law prohibits employment discrimination based on factors such as race and ethnicity. Title VII does not prohibit employment discrimination based on criminal history, but the disproportionate rates at which people of color are arrested and incarcerated in the US substantially increases the likelihood that people of color will have criminal records. For this reason, the Equal Employment Opportunity Commission, or the EEOC, issued guidance for employers back in 2012, clarifying Title VII's limited protections for applicants with criminal records. First, the law prohibits employers from treating applicants with similar conviction records differently due to race and ethnicity. Second, if a hiring practice that excludes applicants with certain criminal histories disproportionately affects applicants in specific racial or ethnic groups, the exclusion must be job-related and consistent with business necessity. So for an employer to exclude an applicant and be in compliance with Title VII, it must consider the nature and gravity of the crime, the time elapsed since the crime was committed, and the nature of the position applied for. While the EEOC does not require individualized assessments of each excluded applicant, employers are more likely to be in compliance with Title VII if they offer excluded applicants individualized assessments, including an opportunity for an applicant to show why an exclusion does not properly apply to their situation. While case-by-case consideration of individual applicants is preferable to blanket exclusions, deeply ingrained systemic racism and implicit bias still render Title VII protections a weak match to the significant barriers that applicants who have been incarcerated face in seeking employment, and particularly applicants of color. Next slide. Now we'll turn to the state level legal issues. First up is the potential barrier to state level CHW certification. So CHW certification is becoming more common across the United States and can affect community health workers and their clients in both positive and negative ways. As shown on this map published by the Association of State and Territorial Health Officials, as of June 2022, 13 states operated certification programs, while at least 8 states have privately operated certification programs. Certification is generally voluntary for CHWs, but at least one state requires certification for CHWs to receive payment from the state Medicaid program, and another requires certification to receive any payment at all. Overall, certification can offer several benefits to CHWs generally, such as recognition and respect as healthcare professionals, improved compensation and working conditions, increased job security and employability, and stronger integration into the healthcare system. Of course, these benefits can help propel creation of dedicated funding streams for CHW roles and legitimize community health workers in the healthcare field. But certification can also pose barriers, particularly to those with incarceration histories. For example, certification processes, which require background checks, may ultimately exclude prospective CHWs from obtaining certification based on the criminal record, despite the importance of their lived experience to serving similarly situated clients, as James discussed. In addition, formalized training programs may pose financial, educational, or language barriers for prospective CHWs who lack financial resources, don't meet educational requirements, or whose primary language is not English. One example of a state community health worker certification law is New Mexico's Community Health Workers Act, passed in 2014, under which the state health department established a voluntary certification program. Only certified CHWs may use the title Certified Community Health Worker, which potentially improves certified CHWs' employability relative to non-certified community health workers. To obtain a certificate, CHWs must demonstrate competency to provide services through training, experience, or completion of an approved training program, and they must complete a background check. Certification applicants with conviction histories are automatically reviewed by the Certification Review Committee and can be denied based on a felony conviction that bears upon the applicant's fitness to provide services. The result is that there are now additional barriers to CHWs with conviction records entering the field. The barriers are not insurmountable in many cases, but they do still make it harder for those best suited to serve reentry clients to access CHW jobs. Next slide. Now we'll talk about healthcare worker hiring restrictions and laws that exclude applicants from being employed as healthcare workers based on prior criminal convictions. These laws vary depending on healthcare setting, type of employer, the specific job or role involved, and the type and nature of an applicant's conviction, among other things. The laws differ tremendously across states and can be difficult to track. One example I'll provide is Wisconsin's caregiver law, which prohibits healthcare facilities from employing in direct client contact positions people who have been convicted of what they call a serious crime, unless they've demonstrated proof of rehabilitation. Though the law does not prohibit hiring people with what they call non-serious convictions, it still requires background checks on all applicants and allows healthcare facilities to deny employment to those who have been convicted of any crime the employer deems substantially related to the care of a client. As a result, this may deter applicants from applying in the first place. And even though the Wisconsin Fair Employment Law prohibits employment discrimination based on having arrest or conviction records, these healthcare-specific laws shift the burden to applicants to challenge potentially discriminatory exclusions. Although these laws are often framed as protecting vulnerable patients, a consequence of these exclusionary laws is that the particularly vulnerable reentry patient population is denied the optimal care that CHWs with shared lived experience can provide. Next slide. Because we'll be hearing from Monsees in a bit and his experience in Minnesota, I wanted to provide a bit of a closer look at the law in the state. First, in Minnesota, CHWs must be certified through the Minnesota State Colleges and University System for their services to be reimbursed by Medicaid. And to complete the state certification program, students must complete an internship, which is often at a state licensed facility subject to the Human Services Background Study Law, which I'll talk about in a moment, that prevents many individuals who've been incarcerated from working in health-related direct client service positions. Because of the background study law, many internship sites are prohibited from hiring individuals with certain convictions for positions involving direct client contact. Presumably, for this reason, the university training program requires students to pass a criminal background check to be placed for an internship. By preventing individuals with incarceration histories from completing the required training program, these Minnesota laws exclude individuals with conviction records from becoming eligible for certification and likely decreasing their employability as CHWs. Next, I'll talk about a barrier to employment. So Minnesota's Human Services Background Study Law, like I referenced just a bit ago, prevents a wide swath of candidates with incarceration histories from working in positions involving direct client contact at certain facilities licensed by Minnesota's Department of Human Services or the Department of Health. Direct client contact includes providing face-to-face care or consultation to clients, meaning that these services could be encompassed within the definition, the services that community health workers provide. The broad range of licensed health and human service facilities, which are subject to the law, includes potential employers such as hospitals. So many prospective community health workers are likely subject to the law's employment prohibitions. In particular, the state law bars covered facilities from hiring individuals to work in direct client contact positions if they've been convicted of a broad range of crimes, including murder, solicitation for prostitution, or first-degree arson, regardless of how much time has elapsed since the discharge of their sentence. Individuals with convictions such as fraud, theft, burglary, forgery, or felony-level convictions, including alcohol or drug use, are disqualified for 10 to 15 years. Additional crimes are subject to a 7-year hiring ban. People with disqualifying convictions may request a reconsideration or variance regarding their disqualification, And the relevant agency commissioner does have the authority to set aside a disqualification if the applicant provides sufficient information to demonstrate that the individual does not pose a risk of harm to any person served by the applicant. And if the commissioner does not set aside an applicant's disqualification, the commissioner may instead grant a variance specifying conditions under which that particular applicant may provide direct care services. Next, I'm going to turn to discussing some of the opportunities, and we can go to the next slide. Now that we have the background on barriers and restrictions, we'll talk more about the opportunities and then policy recommendations. Several legal strategies have been implemented or proposed to facilitate the employment of people with conviction histories to overcome some of these barriers that I've been discussing. Some strategies, though, as I've already alluded to, may have unintended consequences that ultimately hinder employment opportunities for some individuals. So I'll talk through the opportunities and discuss the potential impacts. First, I'll discuss hiring incentives. There's what's called the federal bonding program. And so while job seekers with incarceration histories face barriers to being hired, employers who wish to hire them may also face barriers too. Some insurance companies designate people with convictions as not bondable, which prevents employers from obtaining insurance for these employees. This designation is based on biased beliefs that all individuals who have been impacted by the criminal legal system are untrustworthy employees. The federal bonding program was created to give employers 100% bond insurance coverage at no cost to incentivize the employment of individuals who are otherwise deemed not bondable by insurance companies. Through the program, over 56,000 job placements have been made since 1966. Another hiring incentive is tax breaks. The federal work opportunity tax credit incentivizes employers to hire individuals who have been incarcerated by reducing federal income tax liability by up to $2,400 per eligible employee. Some states also offer tax credits to employers who hire individuals who have been incarcerated. Local jurisdictions like cities may also implement incentive programs, such as the City of Philadelphia's Fair Chance Hiring Initiative, which reimburses employers who hire applicants with incarceration histories for a portion of their wages. Next, I'll talk about certificates of relief and rehabilitation. These can provide some limited benefits to those who are able to successfully obtain them, but the application and review process is often lengthy and rigorous, which places them out of reach for many. And even when an individual, obtains a certificate, many employers don't understand the certificate's nuances and meaning, which leaves applicants in the disadvantageous position of needing to educate a potential employer about the limited relief they provide. And then in circumstances where employers are aware of these certificates, they may expect all applicants with criminal records to have them and penalize applicants who do not. And there are more specific state examples in the issue brief. Finally, one of the most well-known policies that many of you have likely heard of is ban the box. The federal government endorsed ban the box policies through the Fair Chance to Compete for Jobs Act of 2019, which requires most federal agencies and contractors to conditionally offer a job to an applicant before requesting information about an applicant's criminal record. According to the National Employment Law Project, as of 2021, 37 states had adopted ban the box policies or laws for public sector employment, and 15 states had extended the laws to private sector employment. For the most part, ban the box policies are beneficial to prospective employees with incarceration histories. But for organizations that base their models specifically around hiring individuals with lived experience of incarceration, ban the box policies may complicate the hiring process, though there are ways that employers can make clear that roles are designated and designed for those with lived experiences of incarceration. So these employers could emphasize that the role was created with that lived experience in mind without asking about a specific applicant's record. Next slide. So with all of that in mind, what are some of the legal and policy changes that can help facilitate employment of community health workers with lived experience of incarceration? I'll walk through 6 recommendations, and of course, the feasibility of these strategies will vary greatly by jurisdiction. First, health worker certification programs should be crafted with the goal of creating more opportunities for individuals with lived experience of incarceration. There must also be a focus on creating sustainable funding streams for these positions. In designing the certification programs and processes, the certification board should rely heavily on the wisdom of community health workers to ensure that barriers are being eliminated and not unintentionally created. Second, government funds can and should be used to create healthcare jobs for individuals who have been incarcerated. With new guidance on Medicaid Section 1115 waivers that support in-reach and enhanced case management services for people returning from incarceration, state Medicaid agencies have the opportunity to fund and mandate or incentivize the hiring of CHWs with lived experience. Third, local, state, and federal governments can incentivize employment of individuals with criminal histories by expanding existing tax reduction programs and introducing new ones. We know there's a shortage of healthcare workers, and incentives could help close the workforce gaps and provide additional opportunities to historically excluded applicants. Employers receiving these incentives should also receive training on stigma, discrimination, and best practices, as well as funding to create professional development opportunities. Next slide. The fourth recommendation is for the EEOC to issue guidance on hiring practices that are both compliant with ban-the-box policies, while also allowing employers to prioritize hiring individuals with the lived experience of incarceration. The fifth recommendation is that states should take steps to ensure that rehabilitation certificates and waivers are easily accessible for those with incarceration histories and are not overly complicated, presenting barriers to access. States can eliminate restrictions preventing persons with certain convictions from seeking certificates of rehabilitation and allowing instead for individual assessment rather than blanket exclusions. Finally, states should provide guidance and training to employers about how to use certificates of rehabilitation so that the applicants themselves do not have to educate employers on their meaning, and the applicants who do not have them are not penalized. And lastly, states should eliminate categorical bans, excluding people with criminal legal system histories from working in healthcare. Instead, leave hiring up to individual employers and health systems, and issue guidance to support employers in equitably assessing applicants on a case-by-case basis. I'll share one example that we included in the issue brief from the Johns Hopkins Hospital and Health System, which is the second largest employer in Maryland. And the health system has been a leader in hiring individuals impacted by the criminal legal system. The Hopkins hiring model includes key elements such as not asking about conviction history during the initial application and interview process, conducting a background check only after a conditional offer is made, evaluating a candidate's background in light of specifically relevant factors, such as the expected job duties, the nature and timing of the convictions, and whether the applicant disclosed the information, maintaining confidentiality of the background file unless necessary to disclose, and providing a coach to support the new hire. Next slide. I've just linked to the issue brief here, and I know you can't access it, but I wanted to include it because these slides will be up on the website along with the recording, and we can share the link in the chat as well. I'm now going to turn it over to Monsees, who will share his personal and professional experience against the backdrop that James and I have discussed.
Hello and welcome everyone. It's great to see people from all over the country taking time out to be able to be here to talk about this important issue. This issue pertains to me specifically because I was impacted by the hiring laws that exist in the state of Minnesota. I also put something in the chat for you to be able to have a point of reference. I know Michigan was mentioned earlier on their tier system from banning employment, but my name is Monsees Franco. I was born and raised in St. Paul, Minnesota. I currently live in Minneapolis. I am a third generation incarcerated adult, meaning my father was in the prison system. His uncle that he was raised by and looked up to was also in the prison system. And I just come from a family with a history of an incarceration. Nobody just wakes up and ends up in prison. There's a whole factor that exists, and every individual story is different. but mine revolves around the things that I seen, the environment that I was raised in, which really were contributing factors to the way that I would interact with the criminal legal system, starting with being a juvenile. It started with skipping school. It started with graffiti, but it began before then, seeing violence in the home, substance use, a parent who was incarcerated, as I mentioned before. I would be certified as an adult at the age of 17, going into what they call the workhouse, which wasn't prison, but it wasn't the county jail either. So it was the place that was in between. As I would continue and go on through life, I would have various interactions with the criminal legal system until I ended up in prison in 2015. The in 2015, there was a lot of unlearning to do. And I know we're here to talk about banning employment, but in order to get to that, I have to give some of the backstory. I grew up in a home that didn't promote self-esteem. There wasn't the sense of I love you or the words being expressed to show those things. There was neglect and there was abandonment. There was these examples that really impacted the way that I saw myself. And the way that I saw myself was a reflection of how I showed up in community and reflected in the ways that I treated myself. A host of bad mistakes, which I completely accept and own responsibility over, but I'm no longer that person. And when I was in prison in 2015, from 2015 to 2018, I started to develop personal development through some programming that was available, which really helped me to see different pieces of myself that I was, the message that they told me was you're lovable, valuable, important, and powerful. And nobody ever told me that before. So I wasn't really sure that I should believe it. I started sticking with this personal development class, and I started to think maybe it could be for me. Maybe I'll try it. I started to practice some things that reinforced that I was lovable and had value, and that's where my journey began. Also, post prison, my story is just like a lot of other people's story. There wasn't a lot of people around when I got out of prison. I didn't have a place to go to. It was transitional housing. I applied for several different jobs and was hired for one of them. However, the job offer was rescinded based on my criminal conviction, even after ban the box, even after disclosing that I had a criminal record, being offered the position, and the position being taken away upon further review. All of those things happened to me. Started working for a temp agency, really wasn't sure where I was at. Housing situation, which impacts a lot of people reentering into society, was also a factor that I was dealing with. Started to work for a nonprofit um, after the temp agency didn't work out. Also started to develop a sense of community, starting to invest in myself and believe that like a sense of community was what I was always missing. And try to recreate, which wasn't successful in the past. But this time I had a good idea of who I was and where I was going. And I surrounded myself with people who reinforced that for me. I started to advocate. I'm an advocate for people living with HIV, and I also started to get involved in organizations that were pushing for equitable treatment of people impacted by the criminal legal system as it pertains to me. I joined my first board, which was at the Aliveness Project. I started doing different work, advocating and campaigning and marching and real boots on the ground type of work. Through consistency, somebody said that I worked with and had come to admire, there's a job as a community health worker that I think that you should apply for. They're asking for people with lived experience, and it'll be working with the Transitions Clinic Network on connecting people with incarceration and substance use histories to healthcare. And I said, you know, I think I can do that, but I'm not sure because my entire background has been in blue collar work. But I decided that I wasn't going to let that hold me back anymore. And in that way, I said, I'm going to apply for this. And I even had some help with my resume because I didn't know how to paint myself in a picture that was fit to be in a different line of work other than manual labor. And when I was applying for this job, I went through 4 rounds of interviewing. I made it through those 4 rounds of interviewing, and I was selected and hired to be the community health worker for Hennepin Healthcare at the time. And it really spoke to the development of my own self-esteem to be able to go out on a limb and try out for a job that in the scope and nature I was qualified for, but I didn't have the professional experience to back it up. I received the job. There was a 30-day wait period, background check, etc. I'm the type of person that doesn't believe something until it actually happens. At the last, on the 3rd week, I decided, you know, this is really going to happen. I put in my 2-week notice prior to that. Really excited that I would start to earn a livable wage instead of low paying minimum wage jobs that people with incarceration histories are often given. In that 3rd week, I was notified that there was a call that they wanted me to be on a Zoom call. And in that Zoom call, there was the higher ups to Hennepin Health Systems. And in that call, they said, Mr. Franco, we have to rescind the job offer. And I was distraught in disbelief. I've been rejected before. It wasn't anything new. However, there was a lot of emotion attached to this as taking a leap, taking a step out of my comfort zone to be able to apply for a job that I believed that I could contribute to, but just wasn't in my background. Uh, there was a pause, and in that pause, I asked, you know, can you tell me why? There was a longer pause that followed that, and nobody said anything. And I said, was it my crime? Because I disclosed everything. There was no surprises on my end. And they said yes. And I said, what is your fear? And they said, what if it happens to one of our patients or one of our staff members? And in that moment, the advocate in me came out. I said, what if it doesn't? I said, these are the exact systems that we're fighting against. And if you are looking for lived experience, um, in short, you know, I'm the person that was selected for this position. And to take away that goes against what you say you're trying to do here. On that call was a Dr. Tyler Winkleman with the Health, Homelessness, and Criminal Justice Lab. Dr. Tyler Winkleman is connected to the Transitions Clinic Network through the TCN PASS study. Dr. Tyler Winkleman asked me after to stay on a little longer, and we had a conversation with just him and I, and he asked if he could meet me next week. I didn't have anything to lose at that point. And to be honest, I cried. That was a devastating blow to my self-esteem, and my emotions were attached to that moment. In that meeting that I had the week after with Dr. Tyler Winkleman, he said something very empowering, which would change my trajectory to this day. He said, I think that you were absolutely the right person for that job. And since they can't hire you over there, they have a different human resources department. He said, we're connected with Hennepin Health Systems. We have a separate human resources, and we would like to offer you a job position. And in that moment, from tragedy came triumph. And I didn't know exactly what I was going to do. But what happened was somebody took their time out to work with me, and an employer who developed a plan for me to be a part of something because they seen that I was able to contribute to the work at hand, just not in that space with the Minnesota Department of Health and the Minnesota Statute 245C that creates barriers to employment. There are tons of tools to measure recidivism and crime and who's likely to commit it and who's not, but there are no systems in place or tools in place to measure the changes to the head and the heart of people. And in creating complete bans around who can be hired and who cannot, we will never get to know who can truly contribute to the work. Because as Glenn Martin says, the people closest to the problem are closest to the solution. And from my experience in being able to talk with people with incarceration histories, there is a certain layer that exists where you don't need to explain who you are. You don't need to identify what's going on. A person like me, or in the communities that I come from, often we've operated out of survival, and born out of that is a ton of skills that are able to say who is who and what's what. Are you a threat to me, or could you be a potential help to me? And relating to people is that layer that is eliminated in the community health role that doesn't need to be explained. I don't need to over explain or under explain something because we speak the same language. With current laws that are in place and they change around the country, we're really missing out on a great opportunity to be able to take care of people. In a world where stigma exists, any barriers that we can eliminate for hiring practices or to be able to connect people to healthcare is worth the time, energy, and effort. And I just want to thank you all for being on this call, and thank you for keying in on this important issue. And it is my hope that we can take what is learned here today and apply pressure to the systems that have counted out so many people for so long. Thank you very much for allowing me time to speak. I'll pass it back to the host.
Thank you, Monsees, and huge thanks to all of our speakers for sharing your expertise and also your very personal experiences. We really appreciate you being here today and contributing to this important topic. We have some time now for question and answer. I will just jump into the questions a little bit. One of our first questions is wondering about the section 1115 waiver, if we could talk a little bit more about that, what the opportunity is, and then maybe also how the implementation of that has gone, any barriers that have come up in that process.
Hi, everyone. I'm sure you didn't hear me speaking on the webinar, but I'm here to answer questions. And I just want to thank everyone. This is an incredible audience. I've been, reading the chat and all the questions that are come up. So it's phenomenal. We're really excited to share with you all. So I'm going to talk a little bit about the 1115 waiver. So as James mentioned, CMS put out guidance for states that want to use an 1115 waiver to improve connections between carceral systems and health systems. And so this specific guidance is about turning on Medicaid 90 days pre-release in the carceral setting. So I'm sure most people on this call know that when people are incarcerated, they don't have Medicaid, their healthcare is paid for by local jurisdictions or states or the federal government. They're in federal facilities, but their Medicaid is turned off during incarceration. So this phenomenal new opportunity would turn Medicaid on 90 days pre-release. allowing for community health workers and other providers to go into prisons and jails and connect with people to then help support them in their transitions home. And as you heard James say, that having people with lived experience of incarceration really boosts those engagement rates. What we know is that having a Medicaid card is not enough to get people through the door in healthcare systems in the community. I mean, we saw this with the Affordable Care Act when we expanded Medicaid and gave people access, more access to insurance around the country. Many people who were incarcerated had not had Medicaid. And so we expected that once people had more access, we would see more utilization of services like mental health services and substance use treatment services in the community. And in actuality, the data show that that was not the case, that having that Medicaid card wasn't enough to get people through the door. And so, as you heard everyone talk about, having that shared lived experience of incarceration, building those trusting relationships in health systems is really a way to get people to come in, feel comfortable utilizing services and really engage in care, and as a result have better health outcomes, as you heard James say. So it's a tremendous opportunity, so much so that CMS, which is the Centers for Medicare and Medicaid Services, in their guidance actually cited TCN as a best practice. We do have evidence that shows it improves emergency room use, right? So people are less likely to go to the emergency department. They're less likely to be hospitalized when they come out, and they have fewer probation and parole violations and spend 25 days less reincarcerated. So it really improves people's health and well-being and keeps them out of the system. So it's a tremendous opportunity to use these funds to create more jobs for people with lived experience, to use this evidence-based model of care to link carceral systems to community health systems. And yet as you have heard, there are many barriers in hiring community health workers with lived experience of incarceration. And so, for instance, in California, one of the things, we didn't actually have a mechanism to pay for community health workers through state Medicaid in our state. And so one of the things we had to do is we're working on a state plan amendment to then create certification for community health workers to be able to bill Medicaid directly. So here's an opportunity, right, where if things don't go, if we don't intervene, you could see how there could be barriers around criminal records here. So it's one example, as these 1115 waivers are coming to being in different states, of like just in one aspect of the spectrum, we may see some challenges in getting the right people at the table who should be these community health workers. I think I also want to just briefly touch on one other piece of this, which was raised as a question by one of the participants, which is that, sometimes prisons and jails don't let people who have histories of incarceration back into those systems. And so while we do see that frequently, we also do see systems that have figured out how to make this work, right? Our state prison system in California does have mechanisms, people who are lifers, so the most serious convictions coming back into the system to support others inside. And our system knows that that's really valuable and prioritizes that. And in San Francisco, where I work, our community health workers have passes to go into the jail and see clients pre-release. So this is doable. There are ways to still have safety and security within the institutions without, preventing people who have the most knowledge and experience and are the most effective in this work from getting these jobs. So I think the question was raised, like, how do you address that? Do you legislate it? Is it a policy decision? Do you incentivize it? I think these are all really good questions that we're working on. And I think one of the things we want to make sure we do is continue to really center that lived experience of incarceration as the key piece in hiring, because one thing we have seen happen sometimes is that sort of a pivot away from that lived experience to say that somebody, maybe whose family member was incarcerated could fill those shoes in the same way. And I think we know that that's really not the case. And I don't know if James or Monses wants to speak to that aspect, but I do think that it's important to recognize that, not only do people with the lived experience themselves are best suited for the jobs, but also, there's a real opportunity here to reverse the harms of mass incarceration, to peel back some of these collateral consequences through these 1115 waivers. And so I think our job is really cut out for us. And as states kind of start taking this work on, as Monses really pointed out, it's a real opportunity for all of us to collectively work together to ensure that people who are closest to the problem, or closest to a solution, have the opportunity to really affect change. So I know it's a long answer to the question, but I think this is such an important moment in our history. And so hopefully that helps answer the question that was raised.
One quick addition to that question was, does this bypass the CHAMPS application? I'm not sure about that. Does anybody have some more familiarity with that to answer that? Okay. If there's any more information that can be added to the question for that, we can try to come back. Our next question is, could you please provide any examples of tribal nations who have reentry CHW programs in their tribally operated health systems? Any knowledge of that?
I don't know if anyone else in the call has specific knowledge. I know I couldn't cite a specific example, but I do know that in tribal nations that there's community health representatives, which are very similar type positions to community health workers. I'm not familiar with anyone that's specific to reentry, but I know that there is a real opportunity in similar types of roles in the community and supporting people through a variety of social determinants of health and health needs through those types of positions. I would love it if, I don't know if any of the panelists have more specific information about that, but that is something that, we recognize that tribal nations and clinics have sort of their own mechanism of community health workers or community health representatives that are providing this type of work. And so I couldn't cite a specific, great, and somebody just put something in the chat. Thank you.
I would only add to that tribes are federal, and I only have experience at the state level, and so their governing system falls under federal guidelines, I believe.
All right, thanks everyone. All right, the next question, is there work being done on the time it takes to get a background check back for someone with lived experience? We love hiring folks who have lived experience. Our only issue is that the background takes months and months to come back. And this comes from Northern California.
It's the same in Minnesota. There isn't a specific timeline that set asides, as they're called in Minnesota, for them to be returned. And so the process can take however long the state takes, and that's also a barrier for a person seeking employment.
All right, thank you. Next question, what can we do in Minnesota about changing these laws?
That's a great question. There was a DHS background task force that took place the year before and gave recommendations last year. Not all of those recommendations were taken up at the legislative level last year. And even then, they were still restricted to eliminating some crimes, mainly crimes of poverty, like welfare fraud. And there was a real push for persons with substance use histories and criminal convictions around substance use to have those types of crimes eliminated from the DHS background study. So where there are recommendations, I don't have a final on where we are at with that from those recommendations. Oh, that was a place that I also got to testify before and was supported by my lab, the Background Studies Task Force, which was a real opportunity to be able to shed some light on exactly what we're talking about now. And stay tuned for more on that coming out of Minnesota. And what we can do in the future, it's all legislative practices. I really wish that we would adopt some sort of certificate of rehabilitation, something that says when you're, hey, you have been redeemed, you know, nobody is their worst mistake, you know, and we all deserve something at some point that says you have a certificate of rehabilitation to be able to take away some of those things that happen as collateral consequences, because sometimes people are being sentenced under collateral consequences to a lifetime of poverty. If the only job that you ever can get is minimum wage, how do you ever really achieve any status in life, or build generational wealth, or have any sort of financial successes? Success is measured different for everyone, but these collateral consequences, like where you can and cannot work, are amongst a host of other collateral consequences, where you can live, what education you can use, how far you can go, as far as degrees, or certain degrees that fall under DHS background studies as well. And so the more noise that we can make around legislative matters, the better.
Did also things, one says, I mean, I totally agree with all that. And one says, and Tyler Winkleman and many others in Minnesota have been like working very hard on this issue. It's tremendously frustrating to find an amazing candidate and then not be able to hire them because of these state level laws. I did want to touch on one other thing though, is like sort of along the same kind of lines or vein, is that, you know, even in states that don't have those laws, oftentimes we see HR systems really with this idea that certain crimes that are serious or more serious should prevent people from having these jobs. And I think our work at TCN, we do a lot of work in educating hiring systems about why that perspective really doesn't make sense. In California, in fact, and you heard James speak to this, we have many community health workers who have the histories of more serious felony convictions. And if you sort of have that list of crimes that are okay versus not okay, that really sort of leads you in the wrong direction and may shut the door on amazing candidates who come to the table. What we do know is that, you know, the data show that people who leave incarceration after long periods of time have very low rates of recidivism, and actually what we know from our experience are some of the best community health workers, because they draw from a very deep level of experience and knowledge, and are very dedicated to giving back to their community. So I just wanted to kind of point that out as well, in the work that can be done to really, that kind of shows up in these other aspects of hiring, of sort of these beliefs and stigma around the crimes specifically, that even if they're not kind of encoded into law, are sort of encoded in the thought processes sometimes around hiring and risk. And so the importance of recognizing the data and getting even more you know, data to show that this is really, you know, just reinforcing stigma and not what we should be doing when we're hiring. And so I just wanted to make that point specifically as well.
All right, thank you. Our next question, can you talk more about or provide resources towards the financial benefits of these programs for states? I think this might be referring to some of the, or actually, no, I think that might be a good question for TCN with the research you've done on the, yeah, financial benefits for states associated with the TCN model.
Yeah, so we did look at some of the cost savings of our model of care. James spoke to this in his presentation. So for every dollar that is spent in the TCN program, the state saves $2.55. And I think, you know, this is primarily in the carceral space. So, you know, we're bringing in people into healthcare. They have healthcare needs. We, you know, see costs around spending for their care. But because we're preventing people from having probation and parole violations, and they're spending less days reincarcerated, there's a significant cost savings to the state carceral system. And so I think that's a really important piece to recognize, because those are then dollars that could be reinvested back into the community, into hiring more community health workers or more resources for the community. And in fact, the acknowledgement of improving these systems, we know it will be cost savings, and part of the 1115 waiver actually has language that requires that cost savings for states related to some of this, using Medicaid dollars to focus on this work, should be reinvested back into communities.
All right. So this comment is, here in Michigan, they often have issues removing the incarceration status post-release. Does anybody have comments or, experiences related to that you can comment on? No. Maybe if there are any more details that can be added to that question, we might be able to come back to that. Do you have any recommendations for hiring a CHW with drug-related criminal history, lived experience with drug use specifically? A barrier we are facing now is the requirement of a urine drug screening in order to be hired.
I guess I'm just, to clarify that question. So, I mean, it sounds like there's a history of somebody with a history of substance use. What the question is about the requirement. I mean, I think that's something that, would be the kind of thing that you would work closely with your HR system, to discuss. So I would need to know more details on what that looks like. But I think it's just an example of, when we work with sites, we work directly with HR in advance of putting out these positions to try to really kind of think through all of the potential things that might be barriers or issues that need to sort of be discussed in advance. So, the ideal is that you're not getting to a, to the point where, like Monse's unfortunately experienced, where he's being offered a position and then can't take that job. So I think, that just really raises some questions more for me than I have answers for the person who asked the question, but just an example of how it's just really critical to really work out a lot of these issues in advance. And I think it's also important to recognize that oftentimes in systems, this means really going to the top leadership of the organization to ensure that you kind of have every level of support in moving this work forward. We did have a situation once, I remember, with a state in colleagues, where the kind of head of the hospital system was on board but hadn't spoken with the HR department. And so as this kind of moved through, there were some concerns and issues that were raised kind of in the process that probably could have been prevented ahead of time. So I know I didn't directly answer your question, but these are kind of, tricky and thorny situations that require a lot of conversation and training and planning.
And I think this is one of the reasons why we do the important work of training HR staffs and helping them to design job descriptions that specifically ask for those qualities. Having that experience of being formerly incarcerated. In the clinic that I worked at formerly, they had a large substance abuse department, and they look for peers who have former histories of drug use, that have been in that life and have that experience. So they're looking for someone like that, but someone who's not actively involved in those activities.
In other ways I've seen that play out, particularly with outreach and harm reduction, is that some organizations do hire folks that are currently in active substance use, because they are the people that has buy-in with that community. And so in those ways, they see it as being able to reach people that they would not normally be able to reach. And so it really depends on the information that you have and the motive that you are looking to hire a person for. And every organization is different, and they get to decide what it is that they want specifically. But those are some examples that I've seen locally here in Minneapolis.
Thank you. Okay, next question. Are there any pediatric or family-based transitions clinics?
So, you know, the clinics that we put transitions clinic programs in are federally qualified health centers, so they serve families. And so part of our work in TCN is serving individuals who are coming out of incarceration and their family members. So like family members to get care. I mean, the programs are specifically placed in clinics in the community, so people can be with their family members, and the community health workers provide a lot of support to family members in supporting their loved ones coming out of incarceration. But we do focus on adult population, so our network, our model of care are for adults. We've certainly seen a lot of interest in working with the juvenile population of people who are, you know, younger people, children, you know, like transitional age youth that are coming out of the carceral system, and have colleagues that are, you know, developing similar types of models. But Transitions Clinic Network to date has been focused on adults and their family members and supports in the community for these individuals.
All right, we have another question. How do you deal with jurisdictional issues for implementation of CHW reentry programs, given the fact that tribal nations are sovereign nations? I'm raising that just because we're getting a few questions about tribal organizations and CHWs, and I don't think we, correct me if I'm wrong, presenters, I don't think we have the expertise on this call to address those questions. And so I think that might be an area for future presentations or discussion. So we'll take note of that. Thank you. Let's see. I have a question about state law. The CHW certification map shows Minnesota as under construction. So what is currently being done? I'm not sure if Monsees, if you have knowledge of where that stands in Minnesota right now. If not, we can pass along some additional CHW resources for Minnesota. Or if you have a suggestion for like a CHW association in Minnesota that might be a good resource on that.
Yeah, maybe the map that was shown was saying Minnesota is under construction. What I know about Minnesota and the CHW program is that you have to receive a certificate, and so you have to have that certification under your belt, which requires schooling to be able to do that. You can operate as a community health worker while you are taking those classes, but there is a time limit that you have to get your certificate by. I don't know how that relates to people with incarceration histories and community health workers.
Thanks, Monsees. All right. Great. Let's see. Another question, I think for maybe our TCN folks, do you have any examples of policy successes, any like novel solutions to these legal barriers that you would, you know, like to share or encourage elsewhere?
I would say our work is a novel, you know, solution. I mean, I think what I was trying to get at with the other question is like, it's very hyper local, the work that we're doing. I think we work very closely with the clinics that we partner with and trying to help them work through the specific challenges they have. And, you know, I think in kind of navigating what those challenges look like, you know, I think like some of the things that we're doing, I mean, it's not just about, you know, creating the job and then being able to hire those people. It kind of stems very broadly on getting the right people to the table. Like So you can't just post this on, you know, Craigslist or, you know, some hiring website, LinkedIn, and hope that the right person comes to the table. You have to kind of create connections in the community. You have to have community health workers on your hiring panels. You have to create systems that support people once they're hired, and then thinking about ways to support those community health workers in sort of their advancement and workforce development. So there's just kind of a lot of components here. So I think that's sort of the novel piece in thinking about, you know, how do we transform these systems and really support people through hiring. Trying to think if there's anything like specific barriers that, you know, I think one of the key pieces here is I think one thing that's novel is we put this in the job description. I think a lot when you think about hiring people who have histories of incarceration, it's sort of on the back end of hiring, like how do we get people through these systems? One thing that's really unique with ours is it's included in as a required qualification for the job. So that is actually seen as necessary for what we do. And I think that's novel, and really then sort of the cascade of what happens after that is dictated by the fact that we are very front and center hiring people with that experience that's of value and required for the job. So I hope that helps kind of, you know, help people think through, you know, how this is unique and innovative. Clearly, though, if there are some state level laws, it becomes really challenging. And then, you know, I think the next steps, as alluded to, are really working to change those barriers. James, if you want to add anything else.
Right, one more question. Are there any other, especially practical barriers or just other legal barriers that you've encountered that we haven't really talked about today, that anyone would like to mention?
Stigma. Stigma is a huge barrier, and that's something that can't be measured as well. And as we know, all communities are impacted by the criminal legal system. However, Black and Brown communities are overrepresented in the criminal legal system. And I say that to mention that systemic racism exists and unconscious bias exists. And when we are talking about employers across the board, not just in the healthcare setting, but overall, people at the top tend to reflect the dominant culture in America, and the people at the bottom tend to reflect marginalized communities. And so when applying and also having a mark on your record that indicates incarceration history, that can also be a barrier that exists to hiring practices. Some invisible barriers that begin with people with incarceration histories are never seeing themselves in places that that they can identify with. If I don't see myself as if I've never seen a community health worker that looked like me, how would I know to aspire to be a community health worker? And you can follow that example for different roles. And so those are some internalized barriers that exist for people like me in the communities that I come from.
I think to even add to that, I mean, I think that's so true and very important. And then also sometimes we face like practical barriers too. When we do find clinics that are really interested in doing this work, I think it's important to remember that the healthcare system, particularly after COVID, is really strapped. There's a lot of challenges around staffing, and there's a lot of new program implementation. And so sometimes we encounter things like bandwidth issues. And so that can also be a barrier, that even if the intent is to do this work, the work is pushing against these systems of systemic racism. And that takes time and a lot of effort. And so I think that can be a barrier if the reimbursement for the work isn't adequate, if the lift to do the work isn't is too difficult or not incentivized, that can also be challenges. And I think that is one of the things that we're seeing in California, which was sort of an unintentional consequence of our 1115 waiver, is that in addition to providing supports to the reentry population, our state is also providing supports to a whole host of populations, including people who are unhoused or have serious behavioral health conditions. And so because of that, this population is kind of getting, our reentry folks are getting kind of rolled up into services with other community members. And so there's sort of less of a focus on hiring people with lived experience of incarceration because the program itself is you know, sort of being folded into other things. And so I think that's just one example of kind of some of the practical barriers that are faced, and that, you know, we're really seeing it's critical to have incentives for people who want to do this work to be able to take the extra effort and time to really change their systems, to provide the resources necessary. You know, federally qualified health centers are often operating on very marginal budgets or profits, and I think also to have the supports that they need in making these programs work, which is why TCN exists, to be able to kind of walk people through these processes. So I think that's another kind of, sometimes the practical barriers can be quite challenging as well.
Along those lines, Shira, do you have any specific articles or best starting points for teams who would like to bring the transition clinic model to their state?
Yeah, absolutely. We have lots of resources for folks, so I would encourage people to reach out to us. We're happy to share that with you. We do have sort of a you know, a few policy briefs that we put together, you know, that sort of highlight the work and some of the key pieces. So we're happy to share that as well.
Great. All right, I think we have time for one more question. Are there thoughts on this question is recognizing how many people each year are coming out of federal prisons all over the nation. Is there collaboration with the Bureau of Prisons, or maybe are there recommended partners for trying to address the huge, I guess the magnitude of the challenge of trying to reach and better serve people reentering from prison?
I can take that first, and if anybody else wants to add after, coming out of incarceration or coming out of like long-term incarceration, like prison, there are limited resources available. There might be like a handout or a piece of paper that says, you know, these are houses, these are felon-friendly employers, but that list might not even be updated. That could be an out of date information given to people. And so navigating employment amongst many other things, where you're going to live, severed relationships, there's so many things on your plate at once. There are not a lot of organized efforts to be able to connect folks to what they truly need to get back into the workforce in general. There's a local organization by the Power of People who is doing an employment program for people reentering. So it's on the radar, but it's just not invested in on a grander level to be able to include all folks coming out of incarceration.
Thank you. All right, we're about at our time for today. I wanted to thank everyone for attending and for your engagement and the comments. It was really great to have all of these comments and questions. And again, I'd like to thank our presenters for sharing their expertise and experiences with us today. This was a really powerful conversation, and really appreciate everyone's involvement in this. Thank you.
All right, and one final note that a recording of this webinar, along with all the slides, will be available on the network's website in about a week, and you will all be receiving an email when they are uploaded. So take care, everyone, and have a great day. Thank you all.